Tonight's webinar is the first of our three-part series that our esteemed guest, Brett Jarosz, will be presenting on low-level laser therapy. And we hope that you find this session of value to you all. Tonight's event is brought to you by ReaCare. We are an Australian-owned and operated distributor of medical devices across the continuum of healthcare treatment, from rehabilitation to surgical specialty solutions. ReaCare is the exclusive distributor in Australia and New Zealand of Econia's newest line of cold laser, the Evrl handheld laser device for pain relief with unique antimicrobial application that we'll be introducing tonight. Before we begin, I would like to acknowledge the traditional custodians of the land on which we gather today and pay my respects to their elders, past, present, and emerging. I extend that respect to Aboriginal and Torres Strait Islander peoples here today. I would also like to acknowledge the traditional owners of the land which you are on today. Without further ado, let's get started. Brett Jarosz is an ACA endorsed fellow sports and exercise chiropractor and consults at Optimised Sports Chiropractic in Melbourne. Besides sports and exercise chiropractic, Brett also has practice interest in clinical neuroscience and rehabilitation. On top of his busy practice, he also maintains a role as a lecturer for a number of postgraduate education programs, including the International Federation of Sports Chiropractic and Functional Neuro Orthopaedic Rehabilitation. Not only that, but he also finds time to work as part of the allied health team at the Rip Curl Pro Bells Beach. His name is also associated with a number of publications within peer-reviewed journals regarding sports chiropractic, clinical assessment and diagnosis, multimodal management, ergogeneric aids, and rehabilitation. His passion for continuous education will be quite evident tonight as he tries to shed some light on the field of low-level laser. Welcome, Brett. Over to you.
Okay, thanks for the intro again, Anne, and for everyone on board tonight. It's a big topic that we're going to try and cover. So we've got 3 webinars that we're going to try and do this in, and I'm going to go at a pretty decent clip tonight. I've got too much information on too many slides for a 1-hour webinar, and it's going to be very similar when we get to the second webinar. But the reason I'm going to do this is, one, we've got the recording, and so we can go back and you can review any of the information that I've said, as well as the details that are on the slide that I might just skip over. Plus, you'll have the references. Anyone who's been around me when I've presented before, nothing I say is like my original own idea unless I state that it's my opinion. Everything I ever state on slides always referenced, so you'll always have those references that you can go search up yourself and look for. I'll provide those at the end of the presentation. But the big thing that I really want to get across here tonight is I want to start to get the understanding of the basic sciences, physiology. My bias in practice is if we can understand physiological mechanisms, we can harness that in clinic to enhance our patient outcomes. So if I can understand how something works, or better understand how something works, I can then take that understanding and apply it with a greater probability of success for future patients. And so when it comes to the laser field, you heard Anne refer to it as low-level laser technology. You heard it referred to as cold laser. You heard that word photobiomodulation. And one of the things that we're going to see throughout this presentation today, and especially leading into the second webinar, we're going to see that there's a lot of confusion, lack of clarity, whichever type of label you want to give to it, that the words that are used within the literature, scientific literature, you're going to see that there's confusion and there's almost miscommunication, misinformation that's provided even within our research. You're going to see that different light sources, different wavelengths, different powers, different marketing. And we're going to see that the different elements that exist around low-level laser therapy, we're going to see that it sort of puts a bit of murkiness around the whole topic. So I hope that we can provide some clarity over the course of these 3 webinars. And we'll start tonight by going through some of the overview of the sort of agreed upon scientific mechanisms. And then, of course, we're going to introduce the Evrl laser from Erchonia tonight. So just some disclosures from my part of view. My point of view, I should say, is that I'm not an employee of Erchonia or RehaCare or any other vendor. I'm a consumer of their products. So the disclosure is, of course, I'm presenting about the Evrl tonight, this device here, but you're going to see that where my bias comes from this technology is through a journey of, I used to have a class 4 laser and the outcomes I had in clinic compared to what I get with the Evrl. Hopefully over the course of these 3 webinars and understanding and my growth in understanding how light therapy and laser therapy technology works, I think you'll start to see why my biases went to the Evrl, hence I'm presenting on behalf of Erchonia and RehaCare tonight. The next sort of point down from the bottom is, as it relates to anything in any of the presentations, never intended to diagnose, treat, or cure any medical disease processes. Clinical and research information provided is intended to support the normal adaptive physiology of the human body. For those that have been around me know that this is sort of where my mantra lies as such, is understanding physiology, assessing physiology, and using human bodies' adaptive physiology. So if we've got maladaptive physiology, pathophysiology, how can we use various manual therapies, physiological therapeutics, different rehabilitation strategies to enhance a person's normal adaptive physiology? So the information we're providing throughout these webinars is intended to support that aspect. And then if we can understand those physiological aspects across anything, whether it's laser therapy, manual therapy, rehabilitation, etc., just the same as medications, pharmaceuticals do, where they'll use, say, antidepressants for pain management. And if we understand how antidepressants work and serotonin works and noradrenaline works and how that works with the human pain inhibition process, we can understand why people might use an antidepressant, or a medical doctor might prescribe that in order to help someone's pain, but they're using it in an off-label aspect. Same thing can be applied from our perspective, but any topic that I do present that is off-label, I'll talk to people about how it's off-label, but I'm also going to provide the references and the research to support how we can use those things off-label. And of course, the final point is always remain within your scope of practice. So the webinar series tonight, I'm going to go through that overview of those scientific mechanisms. We're going to introduce the Evrl. And then into webinar 2, we're going to start discussing further these scientific mechanisms from tonight. So broader overview of them tonight. Into the webinar 2, which is about 3 weeks away, we'll start discussing those elements. And we're going to have to dive into some of those elements of going back to some physics, going back to biochem, going back to some photochemistry, to actually understand how laser therapy or any of these light therapies work, so we can bring clarity and understand the differences between laser, between LEDs, between infrared. And then as we get into webinar 2, we're going to start to bring in more of the clinical applications of the Evrl. And then finally, once we've got a better understanding of all of those physiological scientific processes of laser therapy, light therapy, etc., we'll then go into some more of these advanced clinical applications where we might start talking about how we can use laser transcranially. We'll start introducing that even today in our clinical applications at the very end from the literature and how they've used the Evrl already transcranially. But we'll start to break down all of these various options of how we can use low-level laser therapy, and in particular the Evrl. So for tonight, we're going to go through an introductory and history on sort of laser, brief overview of that, a couple of slides on the differences between laser classes if you weren't familiar with that, go through those overview, agreed upon mechanisms of how low-level laser therapy actually works and how that physiologically creates the various processes to create the outcomes that we're looking for patient outcomes. And then we'll talk about this biphasic dose response. And again, as an overview that we're going to be expanding upon into that next webinar. And then finally, we'll introduce the Evrl and run through some of the literature and the clinical applications of that as it specifically relates to neck and shoulder pain. So here we go. When we start to look at low-level laser therapy, you're going to see it also referred to as 3LT, obviously with 3 Ls and a T. Can be referred to as a class 2 laser. We'll stop talking about that when we get into the classes. This word photobiomodulation. Now, that term came out in 2015, and it basically is a term to describe all non-ionizing light sources that are basically used for therapy, and that can be in the visible light spectrum or in the infrared spectrum. You're going to see me in the next webinar in particular sort of start to break that down a bit, and I'm going to start to use probably like just 2 words in particular throughout these 3 webinars, being low-level laser therapy or cold laser. And I'm going to usually talk about the word photochemistry. All right, that's going to be our scientific underpinning that we're going to talk about with low-level laser therapy. Now, the NHN designation, there's this non-heating and non-thermal. This is from the FDA. So when devices or drugs get FDA clearances, there's particular processes they have to go through. So low-level laser therapy has a designation of NHN it's a non-heating and a non-thermal device. So instead of talking about photothermal, low-level laser therapy is photochemical. And again, we've got to break down this different terminology and enhance our understanding of these things. And then finally, as we've heard already, cold laser, because the power densities that are used are lower than those needed to produce heating of the tissue. We will understand more about how that works, those photothermal effects versus photochemistry. That will be going into in detail in webinar 2. So the history of that low-level laser therapy is that we've got this modern form of the ruby laser and the helium neon laser in 1961. And so in 1967, Andre Mester, what he did, he was wondering if we took a laser and we shined it onto a mouse, would light radiation, would it cause cancer? And what he actually discovered is that by actually putting laser onto the mice, their shaved hair where he was irradiating them, the hair grew back more quickly in the areas of the mice that have obviously been exposed to the laser therapy compared to those that hadn't. So we also demonstrated that helium neon laser could stimulate wound healing in mice, and then he soon applied those findings to human patients and used the lasers to treat patients with non-healing skin ulcers. So the original thought process was lasers are going to cause cancer. And in fact, they didn't. And he started to see that healing and cellular sort of turnover and growth and improvement, proliferation, etc., that started improving. So now it's been developed into a therapeutic procedure that is used in 3 main ways: to reduce inflammation, edema, and chronic joint disorders, promote healing of wounds, deeper tissues, nerve stuff, and to treat neurological disorders and pain. Now, when we look at the literature that exists for low-level laser therapy, the randomized controlled trials with positive outcomes have been published on osteoarthritis, tendinopathies, wounds, back pain, neck and shoulder pain, post-surgical pain, heel pain, onychomycosis, acne, muscle fatigue, peripheral nerve injuries, strokes, and body sculpting. Now, the ones that I've got listed here in the green bold color, oops, sorry. There we go. So when we look at that particular green color slide, all of those that are in bold green there are the actual literature that Erconia has done the RCTs on, and they've got the FDA clearances for these particular topics within science as to how laser can actually enhance those things. So Again, positive outcomes, and we're talking about, there's been over 100 RCTs, double-blinded placebo-controlled trials, just as it relates to these positive outcomes. And when we start to look at placebo-controlled trials on low-level laser therapy, there's actually 517 articles out there that exist in placebo-controlled trials. So we're talking a lot of high-level studies that have been published in the field of low-level laser therapy, or cold laser. So it's referred to as low level because of its use of light energy at densities that are low. So unlike your medical laser procedures, low level laser therapy is not ablative, doesn't have a thermal effect, but a photochemical effect. And again, that term photochemical is probably the thing I want you to take away from today, as knowing we've got to build on our understanding of how that works. And we're going to overview it and build into it in webinar 2. So the way to view it is think of photosynthesis that we see in plants. So the light from the sun is absorbed by the plant and it exerts a chemical change. It is basically the exact same principle for us as humans, but we have our particular molecular chromophores that we have as humans that absorb certain types of wavelengths of light to induce that photochemical effect. So within the low-level laser therapy literature, the light source and dosage is particularly important. And we're going to start to hear this terminology again, this biphasic dose response. So the light source, i.e. laser, LED, infrared, the dosage of that, so this is the classic joules per centimeter squared. And hopefully by the end of next webinar, you're going to realize that there's a certain number that we're going to obviously be aware of. And then after that, we're going to realize that when we look through the literature and understand our basic sciences, it comes down to the wavelength. And that wavelength is going to be our key thing for inducing these photochemical changes. So low-level laser therapy is characterized by a biphasic dose response where lower doses of light are more beneficial than higher doses. We're going to start to understand why that in fact is the case. So our laser classes, just this overview, and you've probably heard already today, we've said talking about class 2, and we've got 4 basic classes of the laser. They're classified according to the hazard that's associated with them. They're classified for safety purposes based on their potential for causing injury to humans' eyes and skin. All right, so classified based on the potential to damage human eyes and damage human skin. So our 4 main classes 1 and 2, are relatively safe for eye exposure, and the last 2 classes are hazardous for eyes and also for skin. So the eye injury hazard increases as the laser power increases. So our class 1 type lasers, they're considered safe. And so when we're looking at this class 1 and class 2, simple rule is basically the human blink response, that aversion response to light, the class 1 and class 2 lasers, our human blink reflex is basically a protection from that light. Now, if we magnify any of these lasers, obviously, and stare into these lights, obviously we can create damage. But in regards to our classes of laser, they're classified as 1 and 2 because the visible light that they emit, we've got eye protection from our human blink response. When we get into our class 3B and our class 4 lasers, though, this is where we can start to see why they're classed in this way, because the class 3B lasers are powerful enough to cause eye damage in a time shorter than the human blink reflex, so in 0.25 seconds, or the blink reflex is bypassed due to the invisibility of the beam. So obviously like infrared, etc. So in the upper end of the 3B lasers, we can also cause skin burns from 3B lasers. And then when we get to class 4 lasers, and basically when we say to class 4, we're talking about anything that's over 500 milliwatts. Okay, so when we start to hear about some of the various class 4 lasers that are on the market and they're 20 watts and 30 watts and 40 watts. Obviously, that's a big significant number above 500 milliwatts. All right, we're going into the 40 and 50 watt range. And so these are high-powered devices capable of causing both eye and skin burns, and their diffuse reflections may also be hazardous, and the beam can constitute a fire hazard. So again, our classes refer to purely eye and skin damage potential. Class 1 and Class 2 are considered relatively safe, whereas Class 3 and Class 4 are considered obviously hazardous because they can cause that eye and skin damage. So the emphasis for today and the emphasis for webinar 2 is really understanding some of these mechanisms. What we want to set the scene with today is really red wavelengths. As it relates to Erconia's devices, so the Evrl, their accelerate devices, their FX 405s, etc. There are various types of pain, we'll call them pain lasers for today. Using the red wavelength is a 635 nanometer wavelength. And we will go through these different types of wavelengths, focusing primarily on red today. We'll introduce the violet, obviously, because we're talking about the Evrl. But as we get into webinar 2, we will start to talk about the differences between those wavelengths of infrared, red, green, violet, blue, etc., because that becomes a very important part of our understanding of that photochemistry, the physics behind how light therapy can work. So our first law of photobiology states that for low power visible light, and when we start to talk about visible light, we've got obviously our visible light spectrum, and we're dealing with basically the wavelength of about 400 nanometers to about 700 nanometers. So basically violet to red and along that spectrum. So obviously going like your violet, blue, green, working our way through to our oranges, reds, etc. So the visible light spectrum, for have any effect on living biological system, the photons must be absorbed by some molecular photoacceptor or chromophore. So our underlying principle, we talked about it before with our chlorophyll within plants, etc. Absorbing the light, we've got to have something that accepts those photons from the light. Again, we'll expand on this a lot more in next webinar, overview today. Got to have something to accept those photons. And so a chromophore is a molecule which imparts some decided color to the compound of which it's ingredient. So we think with chlorophyll, we think of obviously the green color, etc., within plants. So examples of chromophores can be seen in chlorophyll, hemoglobin, and the one, of course, I've highlighted there is cytochrome C oxidase or COX. The other way to also remember that is this is complex 4 within your mitochondria. So most of the research and the evidence as it relates to, let's just call it laser therapy for now, it's got to do with the COX or complex 4, cytochrome C oxidase. I've said the same thing. You can see this is where elements of confusion lie. That is our chromophore that accepts the red wavelength. So a 635 nanometer to say 660 nanometer wavelength. So in that red wavelength of light, the COX, the cytochrome C oxidase, complex 4 within your mitochondria, that is the thing that's accepting these photons from the red light to impart these physiological changes. So photons that are delivered into our living tissue can either be absorbed or scattered. For our therapeutic effects of laser therapy, we need the light to be absorbed. Scattered photons may be absorbed, but a lot of the scattered photons, of course, are escaping from the tissue in the form of diffuse reflection. So what we're looking for is absorption of that photonic energy, absorption of the light. Now, the energy, a little bit of an overview and preparation, I think, for webinar next month, the difference between power and energy. When we're talking about energy, we are talking as, I'm not sure, we can't see my cursor, sorry, on the screen. But if we look at the picture there on the screen, and we can obviously see on top, it says increasing wavelength going to the right. And then we've got an increasing energy going to the left. We can see our visible light spectrum there down the bottom, about 400 to 700 nanometers. And then as the wavelength shortens and the energy increases, i.e. to the left of the screen, we can see that's where we get to our UV, X-rays, and gamma rays. And then as the wavelength lengthens, the energy decreases, and we can see that's our infrared, our microwave, and our radio waves. The energy is the electron volt that the wavelength is, the photonic energy that it's imparting. Power is referring to the actual unit. So a 40-watt laser, a 7.5 milliwatt laser. That is our power. But as it relates to laser therapy, it's got to do with the energy, and the energy depends only on the wavelength. So the idea of when we start talking about a 7.5 milliwatt versus a 30 watt versus a 40 watt versus a 50 watt, we're going to see over the course of this webinar series that it's got to do with the energy, not the power. And the energy is related to wavelength. So the color of the light. The color of the light, the wavelength, determines the energy of the individual photon. So therefore, the energy, the dose depends on the number of photons on their wavelength, their color. Okay, so it's all got to do with this wavelength and color. So as we see on the picture on the left, blue photons have more energy than green, which have more energy than red, that have more energy than near infrared. So as we work from left to right, we get decreasing energy. Or to say it the other way, if you work from the red down to the blue, we get increase in amount of energy, right? Energy versus power. And so the absorption and scattering of light in tissue are both much higher in the blue region of the spectrum than the red. So we talked about before, we want the light, the wavelength, we want it to be absorbed, the photons to be absorbed. And when we're down into the blue, we've got higher absorption and higher scattering down in that blue end versus the red. The tissue scattering of light is higher at those shorter wavelengths. So the shorter wavelengths is, as we said, moving down to the blue that we saw on the picture before, down into those ultraviolet, down into the X-ray, gamma rays, etc. So tissue scattering of light is higher at those shorter wavelengths. And then furthermore, and again, we'll talk about this a lot more in the next webinar, water strongly absorbs infrared light. Okay, so photonic energy dependent upon absorption. The wavelength is where the energy comes from, or energy, wavelength, color, or think of those as synonymous. The absorption of that photonic energy is what creates our therapeutic changes. Absorption of infrared primarily happens within water. And again, big expansion on that in the next webinar. Then when we look at the action spectrum, shows which specific wavelength of light is most effectively used in a specific chemical reaction. So we've already alluded to the fact that when we look at red wavelength, that 600 nanometer for now, we'll call that range. Evrl uses 635. We know that the red wavelength is primarily being absorbed in the cytochrome C oxidase, or the COX, or the complex 4 within your mitochondria. So the fact that defined action spectra can be structured for various cellular responses confirms that first law of photobiology, which we talked about in the very first slide of this section, which is light absorption by specific molecular chromophores. So we know that the red light is absorbed by that complex 4 in the mitochondria. Now, when we look at the literature, the current research basically says that low-level laser therapy inevitably involves the mitochondria. So when you look at the picture on the left, complex 4 there in that mitochondria also is your cytochrome C oxidase, your COX. Again, whatever it is that you can grasp onto that makes sense for you, we're saying the same thing. The red light's being absorbed there, so it's having effects within the mitochondria. If we kept it just that simple, everyone knows that mitochondria is your powerhouse of your cell. It's where you produce your energy. So as a result, because the red light is influencing complex 4, you're influencing that electron transport chain. Electron, again, we talked about photons and electron volts and wavelengths. And as we move into webinar 2, we're going to see that different color wavelengths actually influence the other complexes within the mitochondria. But for now, we're saying that red influences complex 4. And so as we can see here, the effects that it has on the mitochondria is attributed to the absorption of the monochromatic red visible light by those components of your cellular respiration chain. And what we know is that the effects have included increased proton electrochemical potential. So we said we're going to have to dive into this a little bit more to enhance our understanding, which we'll do in webinar 2. So we've got this proton electrochemical potential changing. So the light influencing the electron transport chain and creating, obviously, that whole process of oxygen, hydrogen, turning, obviously, these things into jumping electrons across to be able to get through to produce ATP. As a result, more ATP synthesis. We have then, as a result, increased RNA and protein synthesis, increases in oxygen consumption, membrane potential, and enhanced synthesis of NADH and ATP. Takeaway from the slide, red light influencing complex 4. As a result of influencing complex 4 within the mitochondria, we're helping produce ATP, we're helping produce cellular energy. So obviously our cytochrome C oxidase, the COX, complex 4. We know that COX is the primary photoacceptor. So it's the thing that's accepting the energy from the red wavelength. As a result, nitric oxide is produced in the mitochondria that can inhibit respiration. So we can see on the picture there on the left side, you can see the nitric oxide there just binding obviously onto iron there in that very top picture there. And so you can see that the nitric oxide produced in your mitochondria, that can inhibit the respiration by binding to the COX and competitively displacing the oxygen. So if you've obviously got nitrogen oxide there binding to a receptor site, obviously the oxygen can't bind there. So what the laser therapy also does is it works by photodissociating the nitric oxide from the COX, thus allowing an immediate influx of oxygen and a resumption of your mitochondrial respiration and generation of a reactive oxygen species. So our general rule, in order to produce energy, we've got to have oxygen in there, we've got to have fuel in there, we've got to have those electrons jumping across that chain in order to be able to produce our ATP. So by having the light coming in, stimulating that process, dissociating nitrogen oxide, we can bind the oxygen to the complex 4, to your COX, and to allow that respiration to occur. Then our reactive oxygen species creates the gene transcription. So basically it produces an overall shift in the direction of greater oxidation. And as part of that shift in this process with that reactive oxygen species, as those transcription factors are basically stimulated along the chain, one of the most important ones is obviously our NF-kappa B. The NF-kappa B activated after low-level laser therapy is instrumental in causing transcription of protective and stimulatory gene effects. So our understanding of the light therapy in a nutshell is right now, red light coming in, that red wavelength, the energy that comes with the red wavelength is absorbed in complex 4 via cytochrome C oxidase. And as a result of that, that light dissociates nitrogen oxide, allows more oxygen to be able to come in, which allows that appropriate cellular respiration, improvement in that reactive oxygen species. And through that process, we get an enhancement in protective and stimulatory gene products. Again, big broad strokes overview that we want to elaborate on more as we get into webinar 2. But light coming in stimulates complex 4 of your mitochondria, production of ATP. Through that process, we can get some downstream cellular responses. And so experiments and clinical studies have all tended to indicate that low-level laser therapy delivered at low doses produce a better result when compared to the same light delivered at high doses. So you've heard me talk about that biphasic dose response before. We're going to have a couple of slides from the literature that talk about this, but it's got to do with hormesis is our more common term, and we're going to hear this word Arndt-Schultz law with the older terms, but hormesis is what we know about now, where if we stimulate things enough, we get a positive effect until we build it enough that we get this optimal effect. But if we go too far, we start to get an inhibitory effect. And if we keep going beyond that, we can actually have negative detrimental effects. And so what the literature shows is that lower doses of light, so this is when we start to talk about this joules per centimeter squared, we know that lower doses of light produce better results than those delivered at the higher doses. And what they've shown is that low-level laser therapy can prevent cell apoptosis, improve cell proliferation, migration, and adhesion. And low-level laser therapy at low dose has been shown to enhance cell proliferation in several types of cells, so fibroblasts, endothelial cells, lymphocytes. When we look at that, we're talking about healing of tissues, we're talking about immune responses, etc. So preventing, obviously, cell death, inhibiting cell death that we can see on the picture there, and obviously helping cells to repair and heal, and this process occurring through mitochondrial production of ATP and energy, so those cells can start to function with normal adaptive physiological processes. So we're taking a cell that may not be working properly, exposing light therapy to it, and that light photochemically is having its effects to stimulate those responses through the mitochondria. And then when we start to look at downstream tissue responses, obviously we're talking about there at a cellular level and then into the tissue. So there's been a lot of different studies on low-level laser therapy and its effects on a variety of diseases and injuries, both acute and both chronic. We can see a collective list there of different things. Again, I just highlighted that second point there about showing that for wound healing, a biphasic dose response favoring lower levels, but you're going to see that across the board with pretty much all of these responses. The thing I want to flag leading into it, and I'll probably talk about this more in webinar 3, is interestingly enough, as it relates to the Evrl, we've said that it's all about light absorption. So that wavelength absorption, those photons being absorbed. And what is fascinating, they're starting to show that porphyrin within red blood cells appears to be absorbing the violet wavelength. And as a result, the red blood cells are then transporting that photonic energy around the system. So we're starting to be able to say, well, we could laser someone's shoulder and someone may actually have beneficial back pain effects or gut effects or immune effects, etc., because obviously of that absorption through the porphyrin and the red blood cells. But we'll expand on that more, but we can see there's downstream tissue responses that can occur because of these photochemical reactions because of low-level laser therapy. And the biphasic dose response, heard me talk about it before, the Arndt-Schultz law. And so this is the law that's frequently quoted as being the suitable model to describe dose-dependent effects of low-level laser therapy. And what the law states is that weak stimuli, as we alluded to before, will slightly accelerate vital activity. So if you look at the graph there on the bottom, obviously on that far left, we can start to see we get a particular dose, and lower doses, you get a certain response. And as you start to increase and get the appropriate dose, you get this optimal peak. As you can see up there, just for the sake of the picture, that's not obviously a real life idea there of a real life research, I should say, of the dose response. I got one on the next slide from a research article. But this idea of we stimulate, we get enough dosage, we get a response until we get to a point we get this optimal response. And then if we go too far, that peak is reached, but then that even stronger dose stimuli will start to suppress the response. And then we can actually get a negative response finally being achieved. We know this terminology in today as hormesis. So Arndt Schultz law, hormesis, interchangeable terms. Excuse me. So this particular picture there on the right, we can see as an actual low-level laser therapy study was done, showing this hormetic effect through low-level laser therapy. So we can see there down the bottom, we've got our joules per centimeter squared. And what we saw there is that in that particular study, just as it relates to joules per centimeter squared, we're not going to worry about wavelengths or anything, but just this biphasic dose response, that particular study showed that if you look at the graph, about 3 to 5 joules per centimeter squared is where they were getting their most optimal photochemical energy therapeutic effects. And we can see that once you start to get to about 10 joules per centimeter squared, we start to have negative responses. And you can see when you start to push 50 joules per centimeter squared, we actually are having negative detrimental effects. So just the words there, it suggests in that biphasic curve that if insufficient energy is applied, there'll be no response. So if you don't put enough energy in there, there'll be no response because you haven't met the minimum threshold. But if more energy is applied, then a threshold is crossed and stimulation is achieved. So just follow the red line up. So we've gone from 0, staying on the bottom of that line there, not really much happening, just got this slow trajectory up. And then all of a sudden you get enough dose there of energy, and then that actual red line starts to creep up. We're getting biostimulation occurring. But then if there's too much energy, then the stimulation disappears and is replaced by bioinhibition instead. And as we said, we can then get to the point of detrimental effects. Now, the one thing for those that, before we get into webinar 2, the idea of joules per centimeter squared, I talked about the idea of power and wavelength before. Joules, the way to look at joules is basically looking at watts per second. So if you look at 50 joules per centimeter squared, you're looking at 50 watts of energy in a second. So if we start to put this idea of like the power of lasers, and we start to talk about 30 watt lasers, 40 watt lasers, 50 watt lasers, we can start to see there with the idea of joules per centimeter squared, 50 joules per centimeter squared being detrimental, 50 joules, 50 watt laser, 50 watts per second. So you can start to see that the idea of some of these high powered lasers may not be actually what we think that they're doing as it relates to basic sciences, and the idea of more power may not in fact actually be the truth. And again, we'll dive into this more in webinar 2, but for those that don't understand the idea of joules per centimeter squared, simple rule is 50 joules per centimeter squared would be the equivalent of 50 watts per second. You can just swap the joules per watts per second. Alrighty, so we're going to get into just an introductory to the Evrl. So big broad strokes overview there of our history of how laser started, where we basically thought it was going to cause cancer in mice, realized that healing processes sped up when when laser was applied to those mice. We've got all these different terminology for laser, and some of that, in my opinion, is leading to a lot of the confusion, as well as this idea of wavelengths versus power versus energy, and even the words that are used and how the research studies are done within the literature. There's a lot of confusion out there, and people will be saying, no, like photobiomodulation doesn't work for certain things. But then we've got to break down what photobiomodulation is, and are they using an LED versus an infrared versus low-level laser therapy, and what the wavelengths were. And we can see the confusion now. And using that term photobiomodulation as an overarching term, which it is, it's to say all light therapy, But if we're trying to figure out, well, what type of light therapy do we want to use for what? Do we want to use an LED? Do we want to use infrared? Do we want to use low-level laser therapy? As we understand the literature more, you'll hopefully start to understand why my bias has actually become towards Erconia's low-level laser therapy, in particular the EVRL. So we talked about that confusion. We talked about then laser classes 1 and 2 are relatively safe for the eyes and for the skin. And we talked about classes 3B and up to 4 are relatively hazardous for the eyes and obviously to the skin, causing burns. So classes have got to do with hazardous nature to the eyes and to the skin. And then when we went into the mechanisms there, we've said the overview was it's about wavelength. It's about the energy of the wavelength, and it's about things within biological tissue that can absorb that photonic energy. And through most of the literature, it's been done on red light, wavelengths in that 600 nanometers, and it's showing that it's the complex 4, COX, cytochrome C oxidase, is that photoacceptor within the mitochondria that's helping produce ATP, that's helping them produce, obviously, with our reactive oxygen species, gene transcription, creating downstream cellular effects, downstream tissue effects. And then we just talked about the biphasic dose response and how we need enough energy to create stimulation with an optimal level amount of energy. And just to give you some hints and some insights, this optimal level of energy is sort of appearing to be around, say, the 5 joule mark, but basically we don't want to go above 10 joules per centimeter squared. We definitely don't want to be going above 15 joules per centimeter squared. We want to be working basically less than 5 joules per centimeter squared, as we've seen through the literature there. This idea of lower doses appear to have more beneficial effects. We'll expand on that more during webinar 2. So without further ado, we'll introduce the EVRL. So Erconia was founded in 1996, and they've remained committed to the advancement of low-level laser therapy, which has allowed them to become basically the world leader in the field of low-level laser therapy. Through their scientific and clinical studies, there are 25 different FDA indications for low-level laser therapy, and Erconia owns 20 of those indications. So Erconia is the one who has been doing the randomized, double-blind, placebo-controlled trials. And they're the ones, as we showed you before, with the different types of randomized controlled trials showing positive outcomes in those different fields of back pain, neck pain, acne, body contouring, etc. Erconia is the one who's got 20 of the 25 indications for it. So they're the ones who have done the research. They're the ones who have put their money to figure out how these things work and to show whether or not different types of wavelengths, different types of power, etc. works. So since its release, Erconia's newest handheld laser, the EVRL, now obviously got the older one. The newer one is the one that's just come out in Australia. As it's become the most popular handheld device throughout the US, and I think throughout the world now in terms of the popularity of it, because it offers the versatility of the red and violet wavelength. Now, you heard me talk about the violet before, and so just for people to be able to see it right now. So we'll go there. So we can see obviously the red and then the violet just going with that one there. So when we look at the red wavelength, we talked about COX, cytochrome C oxidase, complex 4. When we start to talk about the wavelength of violet, 405 nanometers, and we're going to start to see the other effects it has through, as we talked about before with porphyrin on the red blood cells, where we're going to see how it has an impact in different complexes within the mitochondria. We're going to talk about its different electron volts during webinar 2, and we're going to start to see the different clinical indications for the red and the violet wavelength as it relates to photochemical effects. So as it relates to specifications, we can see there that the red diode that we have there is a wavelength of 635 nanometers. It's a 7.5 milliwatt. We talked about that idea before of watts, 50 watts, etc., versus milliwatts, and the violet is less than 5 milliwatts. I believe the newer ones that you're going to be having for convenience, so they're not making two separate diodes. I am under the understanding that the EVRL will just both be two 7.5 milliwatts. So obviously both very, very low level, obviously class 2 laser. Now, what they've shown is by combining the two specific wavelengths into one modality, as you saw before when I was showing it to you on my head, they've shown that patients receive better results during clinical studies than just using the 635 nanometer alone. So if I just show you this, so Erconia, this was one of their FDA clearances. The results they got from this were that good that the FDA made them go and repeat it. And they repeated it and they got the same results. So showing that using that 635 nanometer red, they obviously showed their results, exceeded the pre-established criteria for the overall success success. So visual analog scales decreased from 60 to 31 for those that had the low level laser therapy. So those that used just the red wavelength on this, compared to a change of 60 to 55. So we can see, we saw an improvement of nearly 30 in the red wavelength. And then those that had the sham, now what was the sham? The sham was 635, a red wavelength, but LED. So the sham was LED, laser versus LED. So the placebo, again, was LED. And we'll elaborate more on this in webinar 2. So there was a difference of 24 points between laser and LED. And not only that, with the pain aspect, there was also significant improvement in range of motion by those that were treated with the laser, but not with the LED, and no reported adverse effects. And in fact, there has been not one reported adverse effect with any of the Erconia laser studies. But then what they did is they went and compared, what if we then did the violet and the red together, and we compared that to just doing red. So they did the exact same study protocol, but they applied violet and red to one group and they applied just red to the other. And what they saw is that those, and it was just one treatment, all right, just one treatment to compare. Among subjects that were treated with the red and violet, their average VAS neck and shoulder pain scores, obviously you can see the decrease in there. Again, the decreased mean scores, they also remained at 24 and 48, actually got better. They continued to improve at 24 and 48 hours respectively. And the secondary efficacy measures of neck range of motion and then patient satisfaction with no adverse reactions were also there. So overall, Erconia did their research and showed that using the red and the violet combined outperformed their already FDA-approved red laser with respect to changes in pain scores and improvement in shoulder range of motion. So as it relates to understanding like the basic protocols for using these particular lasers, we've got a few options just to sort of start talking through. So for those that have got the EVRL or an equivalent laser, we've got our basic research-based pain treatment protocol. So within the EVRL, you've got an ability to put these different frequencies in. We're going to talk about these frequencies and what they mean more, especially as it gets to our transcranial applications and those wavelengths that we understand because of EEG studies, QEEG studies, etc., and understanding, theta, delta, alpha, vagal frequencies, etc. So we'll be able to understand these frequencies a little bit more, but view them as the cherry on top. The magic basically is happening. It's not magic, of course, it's photochemistry, but where those therapeutic effects are occurring is because of the wavelength. So the frequency settings that people would input into the EVRL is we've got our 9, 16, 42, 53 as our frequencies. Obviously the 9 and the 16 are for the violet and the 42 and 53. So this is what they used within their research study. Basically the sweet spot for treatment distance is about 10 centimeters. But what I just wanted to show you guys here is because they've got this patented optics in here, let me go this way. So if I go to the side of my head, what we can also do is obviously if 10 centimeters is a certain, I can't see how far 10 centimeters away from my head right now, but if 10 centimeters is a sweet spot, we could also go, well, if I want to span from the whole front and back of my head, I could just pull this away so that the beam could cover that whole treatment area. So if I wanted to go and treat across my whole pec, as an example, I could pull it across and have that thing across the whole pec, versus if I wanted to get this on my finger, I could just go and put it straight onto my finger there. So the aspect of the laser beam length is another benefit that we can use, but 10 centimeters is about that sweet spot for treatment distance. And we want to orientate the laser perpendicular to allow the most photonic energy to be best absorbed into the tissue. Now, our point and shoot process is just point this at an area and just point and shoot it for 10 minutes. Your minimum treatment duration is 2 minutes. So that is your very basic pain treatment protocol, whether it's for shoulder, elbow, neck, low back. Now, we're going to talk about the low back and the neck and the heel pain. We're going to go through all these studies in more detail than neck, shoulder today. But our basic protocol, we set that up, our pain process, 9, 16, 42, 53, hold it about 10 centimeters away from the target. You can basically fan it over the area or wand it, whatever the word is you want to use, over the area. You can just have it sitting and pointing at that direction, at that area directly for 10 minutes, or minimum treatment of 2 minutes. When we look at the research protocol that they use, though, that's what they actually did in the literature. So the same frequency settings, but what they did is that they did 1 minute on the apex of the head there, that sagittal suture. And again, we can start to look at this as parietal lobe influences, obviously body maps, knowing where our body is in space. Some people talk about that as being like one of the brain points, obviously from a different types of, Chinese medicine treatment processes, but parietal lobe. Then they started working obviously on the left side, right side, from the top of the ear down through the neck. And as you can see, through those anterior, posterior muscles, through the front of the shoulder, back of the shoulder. And they did the same thing, 2 minutes on the other side. Then they did 1 minute of lasering the arm with external rotation through the front. Then they did another minute on the back where they were taking the arm into adduction and lasering the back of the shoulder. Then they did 1 minute of lasering through the traps, doing lateral flexion from a neutral position. Then they did the SCM, again, just doing passive ranges of motion, and then repeating the same process on the other side. So that was the actual research protocol, 13-minute treatment duration. So when you look at it so far, you've heard this idea of you could just do point and shoot with this laser, and you can just simply 10 centimeters away, or move it out to get that beam over the directed area, or you could wand it and you can just point and shoot at it for a minimum 2 minutes up to 10. And then you've got obviously the more advanced types of treatment protocols here that you can see from the literature, where we're covering a greater area. When we get into webinar 2 maybe, but definitely webinar 3, I'll start to talk to people about these idea of swimming upstream and swimming downstream approaches of how we can use the laser, brain, cerebellum, vagus, spinal cord, nerve root, local areas, and how we can either go from the actual local area and swim upstream, or how we can start from the brain down and swim downstream. You'll also see with Erconia, their website has actually got this particular YouTube clip. I'm not going to play it, but just so you can see at the start. And they've got links here for you so that you can see the basic processes of how the EVRL works. So in that particular webinar, they'll talk about, hey, you can point and shoot. You could point and shoot and you could just like add some movement. You could point and shoot and then add some resistance with that movement. We're going to enhance those protocols, but take away from today, we've got the literature showing their pain protocol that they use, that 13-minute process for neck and shoulder pain. We've got a point and shoot option, and you've got the idea of just point and shoot and add movement, add resistance. When we get into the next webinar, we will talk about more of these advanced applications, go through the literature of what protocols are for the back pain that have got FDA clearance, for heel pain, for acne. Go through these things that the EVRL has got those FDA clearances and literature for, and we'll keep expanding on these things through webinar 3 so we can see how we can utilize these lasers for various clinical applications. But if we understand those basic premises first, and we can get some clarity within the literature, which I really hope I can do through the next webinar, I think we'll be in a pretty good place to understand these differences between the different types of photobiomodulation therapy. So our references for tonight, we've got all these various, obviously some of the websites about lasers, but obviously our references from the literature, they're going to be our big ones.
Thank you very much, Brett, for your time, and we hope to see you in a few weeks' time. Good night.